Dealing with an iris prolapse during phacoemulsification surgery comes with its own challenges. Now, depending on the timing of the iris prolapse, which very often is towards the beginning or the middle of the surgery, there are various challenges. And the fact that the iris is prolapsing out of the incisions makes the instrumentations via the paracentesis incisions very difficult and therefore the surgery equally challenging. And once we have an iris prolapsing either through the paracentesis incisions or the main incisions, there's always a chance of further damage to the iris should it continue to remain prolapsed. I'd like to share with you a very simple trick of how to overcome this challenge when we have an iris prolapse during phacoemulsification. Let's move to watching the surgery. Here's a patient with a grade 2 nuclear sclerosis with a fairly well dilated pupil. I'd like you to watch my incisions. That was the main incision, the left paracentesis incision, and a fairly well constructed right paracentesis incision. We'll proceed with the staining of the anterior capsule with blue dye, after which it is washed out. The air and the blue dye washed out to the eye and replaced with viscoelastic, after which we proceed with the capsulorhexis. We've completed the capsulorhexis, the anterior chamber decompressed, after which we proceed with the hydrodissection. Viscoelastic is introduced into the anterior chamber, and then we proceed to the nucleus disassembly and emulsification. The technique of my choice would be a direct chop, and prior to the nucleus emulsification, I always aspirate the cortex overlying the nucleus. We proceed with impaling the nucleus. At this point, we start with the first chop. Having successfully divided the nucleus into two halves, here's what I notice. You can see the iris tending to prolapse out through the right paracentesis incision. At this point, because there just seems to be a tendency and it's not really prolapsed, I rotate the nucleus and divide the first heminucleus into two halves. With the help of a chopper itself, I then push the iris back into the anterior chamber. And having regained the iris back in its normal position, I choose at this point to continue with the surgery. Once more, the nucleus is rotated around. The second heminucleus comes to lie opposite the phacoprobe, after which it is impaled and the second heminucleus divided into two halves. Once more, you can see the tendency of the iris to prolapse. Something needs to be done here. Now here's what I do. In order to keep the iris from prolapsing further, I introduce a dispersive viscoelastic in the area of the anterior chamber close to the side port where the iris was prolapsing. For the rest of the anterior chamber, I introduce HPMC. Now let's see if it works. I reintroduce the phacoprobe through the main incision, and via the same paracentesis incision, the chopper is now replaced by a dialer, and I proceed with the emulsification of the 4 fragments now created. The first fragment has been emulsified. We now emulsify the second fragment, after which the third and then the fourth fragment are emulsified. Notice the iris during the fragment emulsification. The dispersive viscoelastic is still retained there and prevents the iris from prolapsing any further. At this point, we've completed the nucleus emulsification. I now proceed to the epinucleus removal with the epinucleus mode of phaco itself. I'd like you to note that throughout the fragment emulsification and the epinucleus removal, the pupil stays round. Now, towards the end of the epinucleus removal, there seemed to be a slight tendency of the iris to prolapse again. Now, prior to the removal of the cortex, once more I introduce a dispersive viscoelastic in the area under the right side port incision, and for the rest of the eye, I use HPMC. And then we proceed with the cortex wash using the bimanual irrigation aspiration. As you can see, there's still a thick epinuclear plate which resists being removed with the bimanual irrigation aspiration. Therefore, I go deep to it with the irrigation, elevate it out of the capsular bag, after which I attempt to remove it with the bimanual irrigation aspiration. Removal of the epinucleus with the bimanual irrigation aspiration just tends to take a little longer. As you can see now, we've completed the epinucleus removal with the bimanual irrigation aspiration. And prior to the removal of the rest of the cortex, once more I inject some dispersive viscoelastic in the anterior chamber on the right side. With some normal HPMC introduced in the rest of the anterior chamber, I now proceed with the bimanual irrigation aspiration. I'd like you to notice how the anterior chamber is maintained throughout the bimanual irrigation aspiration. The dispersive viscoelastic on the right side under the right paracentesis incision prevents the iris from prolapsing throughout the bimanual irrigation aspiration. This is what you will see in this part of the video. There seems to be a slight tendency of the iris to prolapse on the left side, as you can see. Following the removal of the irrigation cannula from the left paracentesis incision, you will notice the iris tending to prolapse on the left side. And to prevent it from prolapsing any further, I introduce a dispersive viscoelastic under the left paracentesis incision and then proceed to complete the bimanual irrigation aspiration. With this, as you can see, we've completed the removal of the cortex, after which HPMC is introduced into the anterior chamber and we proceed to the implantation of the single-piece monofocal IOL in the capsular bag. Following the successful implantation of the IOL within the capsular bag, I now proceed to the visco wash, wherein the viscoelastic is removed from within the anterior chamber and from behind the IOL by a gentle rock and roll of the IOL optic. As the viscoelastic is washed from the anterior chamber, you will notice a slight tendency to iris prolapse once again. With care and caution, all the viscoelastic is removed from the anterior chamber. After which, as you can see, the wounds are hydrated, thereby bringing us to the end of the surgery. And therefore, in this video, we've discussed an extra step that can be performed whereby you can reduce the occurrence of an iris prolapse should there be a tendency to do so by the introduction of a dispersive viscoelastic in the anterior chamber in the area where the tendency to the iris prolapse exists. I hope you found this video tutorial useful. Thank you.